Alrighty, welcome everyone. I'm Karan V. I'm a registered nurse and a Master's of Nursing student at University of Manitoba. I'm so glad that you have all joined us this evening for 11th Annual APN Conference.
Good evening. I'm Melissa, registered psychiatric nurse from Brandon University, also completing my Master's of Psychiatric Nursing. And I just want to say thank you to the Advanced Practice Nursing Committee for inviting Brandon University to partner for this conference for the first time.
Welcome, Melissa. So before we go any further, I would like to pause and acknowledge that we are proud to recognize that of all the traditional territories upon which nursing profession works. We acknowledge that we are in Treaty 1 territory and that the land on which we gather is a traditional treaty territory of Anishinaabe, Cree, Oji-Cree, Dakota, and Dene people, and a homeland of Métis Nation. We respect the treaties that were made on these territories, and we acknowledge the harm and mistakes of the past. We dedicate ourselves to move forward in the partnership with Indigenous communities in the spirit of reconciliation and collaboration. Okay, thank you. So our goal for this conference is to provide an opportunity to all of the nurses to share their stories, learn from each other, and support each other, which is going to strengthen our wonderful profession. We want this conference to be an open and safe place where you are comfortable to speak and ask questions, as well as invite to share you experiences and perspectives about the topic being discussed today.
So just a few housekeeping things before we get started. Although the forum is being recorded, attendee information and any identifiable questions and answers won't be shared. Right now, everyone's microphone is muted and webcams are off. However, we do want to hear from you. If you are experiencing any technical issues, please use the chat function to let us know and we'll try to troubleshoot with you. Sometimes it's as simple as making sure you've joined via your computer audio or turning up the volume on your device. If you have any questions or comments, please share them by using the Q&A function on the bottom of the toolbar, and they'll be answered at the end of the presentation during our panel discussion. Before you click submit with your question or comment, you can use the drop down to choose how it is shared. It can be with everybody, just privately to the panelists, or anonymously. And with that, it is my honor to introduce Leslie Spillett, Knowledge Keeper in Residence for Faculty of Nursing, for our blessing and welcome.
So, wache, Gejiko Eabi Kwe Indigenikas, Makwado Dem, Wikasko Dunji, and Winnipeg Treaty 1 Dunji. My name is Painted Sky Woman. I belong to the Bear Clan, and I'm originally from northern Manitoba, from Ininewek, from the Cree people. And also my ancestry on my father's side is European ancestry. I embrace both my lineages. And I wanted to say how really honored I am to be with you this evening. I want to acknowledge Dr. Dick and all the colleagues from the College of Nursing, and all of the committee members from the Graduate Nurses Association, Students Association for making this evening possible. I want to also acknowledge the amazing Navsharn who brought this beautiful pouch of tobacco all the way from Peru, and she put in some incense sticks in there. They're gorgeous. It's a gorgeous smell. So it's a big honor for me to receive tobacco from our relatives in Peru. I was telling her earlier that is on my bucket list, that beautiful land. And yeah, so I want to just appreciate this gift that you've given me as a committee. Well, I'm so honored to work for the College of Nursing and work with our students. I'm particularly associated with our new name for the ANSI program. So we call it Makwa o Mashkikim, and it's kind of a distinctive way to identify Indigenous students within the College of Nursing. I really love the topic tonight. I think it is so critically important that we connect, and I loved how you've done it by the support that you've given to SHADE, but connect preventative health with social justice essentially, because we know that the social conditions that people live in have a lot to do with whether or not they can take individual control or individual agency over their own health outcomes. And we know we live in a city, in a province that's very wealthy, and yet the distribution of resources are not done very well, and it is associated with poor health outcomes. And I also want to acknowledge that, even within that, our collective response to one another, we also have a responsibility to take care of our environment, because that is also preventative health. If we don't have clean air, water, a healthy earth, a productive earth, and access to sunlight, we also have a very big problem. And I think that we can kind of associate that, or I certainly associate it, and many of my colleagues and scientists associate this kind of environmental problems that we've experienced also has a direct impact on the health of people, on the health of all life on this planet. So we need to think in our own responsibilities, our collective responsibilities, and then our big social responsibilities. And I really want to kind of frame it in that way, because in our worldview, we're taught to think of 7 generations that have come before us, but also 7 generations that come after us, those that are still coming. And we know our children are I think, being the strongest advocates for environmental justice. And we need to be able to, tell our grandchildren like what we did to ensure that they had a world worthy of them. And so I want to just acknowledge the good work that's been done to put this together. I'm really excited to hear from all the panelists to kind of knit together various concepts around health and justice. And I know that we all pray in very different ways, and I love all the ways that we pray. And sometimes, we just believe in that life force, and that's okay, whatever we believe in. And in my way of praying, I ask those grandmothers, we call them ancestors. These are our grandmothers, those ones that went before us, and they are still our great grandmothers, of course. They are still have access to us, even though we're not able to physically, visibly see them. We believe that their spirit is still present when we ask them to come in. And so I say miigwech to the Creator for life, for this beautiful day, for these beautiful people that have come here together to share, to provide information, to support one another. And I ask for blessings for this time that we have together. I ask for a safe space for everybody to grow and to learn and to contribute. And I just feel so honored. Always feel honored to work with nurses. I've developed quite a love for nurses, just to let you know, in the last little while. I like the doctors and I like the OT, but nurses have my heart, because in this last year, they've gone to the front line of the battle against COVID, and we have to acknowledge that they are our heroes and sheroes, and I want to acknowledge them tonight for their for the love that they have in their hearts to do this work. So Nadilaway, Maganaduk, all my relations, miigwech.
Thank you, Leslie, for your blessing and your thoughts. So before we delve into our tonight's topic, it is my honor to welcome Dr. Nita Deg, Dean of College of Nursing at University of Manitoba, to share her wisdom and thoughts with us. Her support and commitment to the well-being and education of all nursing students is invaluable and highly commended. Thank you and welcome.
Thank you very much, Karen Veer. And thank you so much, Leslie, for your blessing and for your presence here this evening. Good evening, everyone. As Dean of the College of Nursing at the University of Manitoba, I am delighted to welcome you to the 11th Annual Advanced Practice Nursing Conference. I am thrilled that there are more than 100 participants registered for this evening. Thank you very much for your participation and your support. I'm also very pleased to welcome our special guest that is with us this evening, Dr. Jane Karpa, Program Coordinator of the Master of Psychiatric Nursing Program at Brandon University. Welcome, Jane. We appreciate your exemplary leadership and your presence and support here this evening. I congratulate the Graduate Nursing Students Association for organizing and hosting this special conference and thank the Planning Committee for their excellent work. Given that most of our graduate students are working while studying, it is a huge accomplishment for them to have hosted this conference for 11 consecutive years. I would also like to commend the co-chairs of GNSA, Jane Kraut and Jocelyn Elias, and their entire executive for the excellent leadership they are providing and their active engagement in a range of impactful initiatives. I commend the GNSA for proceeding with this conference despite the pandemic. While the virtual format is a new way of delivering the conference, we've all gained experience with virtual formats this past year, and so it should facilitate the ease with which we can all participate. And I'd also like to acknowledge the GNSA on its leadership and initiative in making this conference a provincial event this year through its collaboration with the Brandon University and the Association of Regulated Nurses of Manitoba. You have chosen to address a very important topic this evening, the APN's role in preventative health and health promotion. Advanced practice nurses play a key role in preventative health. At the College of Nursing, we are privileged to have the opportunity to provide graduate education to prepare advanced practice nurses for this critical role within the healthcare system. So I look forward to hearing from the panel of speakers this evening. 2020 was a very special year in that it marked our 40th anniversary of our graduate programs in the College of Nursing. We celebrate the delivery of our master's program with its 4 streams of administration, education, clinical practice, and nursing practitioner, and also our PhD in nursing program. Through our graduate programs, we have prepared more than 565 nurse leaders, educators, clinical nurse specialists, and nurse practitioners who are providing exemplary service and leadership in the healthcare system. In 2020, we also celebrated the 35th anniversary of the college's Manitoba Centre for Nursing and Health Research. The center provides tremendous support to students and faculty in their engagement in research. So I'm excited about this special conference this evening. So thanks again for coming and enjoy the evening.
Thank you, Dr. Dick, for your kind words. Our first speaker we have today is Barbara Catt. She is a registered nurse and holds a Master of Education where her research was focused on adult learner principles. Welcome.
Thank you so much. And I'm going to share my screen. Share. Do you advance these slides?
I think you can do it from your side, Barbara.
Okay, that's great. Can everyone see that?
Yes.
Yes, okay. First of all, I'd like to thank the conference committee for inviting me to speak. And it's a topic and a profession that I'm extremely proud of and very passionate about, and it's infection prevention and control. I'll go into a little bit more detail with Sorry, just trying to go further. I have no disclosures to acknowledge at this time. And then lastly, I do want to thank our frontline leaders, particularly our national leaders, Dr. Teresa Tam, as well as our frontline workers, essential service workers, including our truck drivers, and then as well acknowledge the many patients, families, and residents who have actually been affected by this infection. So my objectives is just to provide you a brief background of what my experiences are, speak on 3 main significant coronaviruses, and then go into how preventative health and health promotion is infection prevention and control, or as we abbreviate, IPAC. So going into my background, I actually started as a diploma nurse, and I was the last diploma nurse coming out of Ontario, and it was a 2-year program at that time. So that's giving you a little bit of my age. And I actually worked in a variety of healthcare settings, including at emergency nursing, ICU, specialty, long-term care, as well as I was a mentor with the local college. I did go back. I had an interest in going back, completed my BSCN, and I knew that it definitely wasn't enough education, that there was so much out there that I just love learning. And my last job before I went into infection prevention and control was an operating room nurse. And I have to be quite frank, probably was one of my most boring career choices that I ever had, was operating room. Now that was just, again, my personal preferences. At last, I was teaching at the university and college, and then SARS in 2003 hit, and hence I ended up going to a facility into Toronto to help or assist with that first outbreak in SARS. So I'll speak to the 3 significant coronaviruses that you see here. And coronaviruses are actually a number of viruses. There's numerous, many large family of viruses that actually originate in animals. So we know that many animals are what we call mixing vessels for a lot of these respiratory viruses. And they've been known to cause respiratory illness in humans, and there's 7 coronaviruses, 4 of which cause very mild symptoms in the human, such as a common cold. And then we have these 3 viruses that actually have severe acute respiratory symptoms, and I'll go into a little bit of each one of those. So we begin with the SARS-CoV-1 virus, and let me just, sorry. With SARS coronavirus, it began in 2002 in Guangdong, China. When we looked at the case fatality rate, which was 9.6, it didn't sustain a lot of transmission throughout the world. As a matter of fact, there was approximately 24 countries that were affected with this coronavirus. There were 8,998 people who became sick, and 774 that actually died with this disease. And as we know, it in Toronto, here in Ontario, we had the largest cluster, which started in one of our a travel-related history, and it started in one of our acute care hospital settings. I'm just having difficulty with one of my program here, sorry. So in 2003, I actually ended up coming to a facility that actually the hospital had transferred all of their acute care patients into this facility. And it was an undisclosed site at that time. And believe it or not, it was a brand new long-term care home. So you can appreciate challenges with long-term care homes as opposed to working in an acute care setting. And it wasn't just about staffing issues as it was logistics and having available, for example, IV pools and those types of things. So we really had a lot of we had approximately 200 patients during that time frame in this facility. Then I was helping out a large tertiary care hospital, and actually this is an actual picture of one of our staff members back then. They brought in striker suits over the Easter weekend. So think about the timelines when, for example, with this coronavirus in the fall of 2002, and here we are, April 17th, Easter weekend, when we actually brought in these striker suits because of the fact that we still hadn't identified what the organism was. And we actually had staph transmission during that time. So next, July 2003, funny about this organism, as fast as it started or appeared, it disappeared. Canada had a vaccine for this first coronavirus, and because we had a vaccine, we had no population to test the vaccine on, so therefore trials were not, we weren't able to do any trials with this vaccine. Sorry, I'm losing my voice. Next, in 2012, I had an opportunity with Accreditation Canada to assist the Saudi Arabian Peninsula and assist the Middle Eastern Respiratory Syndrome virus, which is abbreviated as MERS-CoV. This outbreak actually began in 2010. Believe it or not, it is still ongoing. And one of the biggest things with Accreditation Canada that we were hired to do was to educate their healthcare providers. Now, in this next slide, you can see here MERS-CoV, and when I talked about the animals that are used as mixing vessels, you can see right from the cattle, horses, and goats, baboons. These are actually animals of interest that they were doing some testing on. And then the yellow animals, such as the bats and the alpaca, were more of the ones that actually displayed symptoms of like a mild cold. And then when we see these red pictures here, the camel and the human, this is where actually the susceptible hosts are, and I'll go into as to the reasons why. When you look at this picture, this is very common in Saudi Arabia where we have these dust storms. And what they were thinking was the excreta from the bats actually was stirred up by these dust storms, which transferred into the camels. And this is an actual picture when I was over there. It was transferred into the camels. And this is where they were saying if individuals worked on camel farms, they actually did drink and eat the camel milk and meat. So that wasn't uncommon. And that's what I was saying earlier around them being the susceptible host. So one of the biggest struggles that I had when we were doing our sessions over there was English was not their first language. And of course, the language primarily was Urdu. And many of this population here could not write or print their name, but yet the ministry was the ministry in Saudi Arabia were the ones that actually provide us with the slide deck. And there wasn't any principles of adult learning with this type of group. So a lot of what we were doing is we had a translator and then actually did some more of the demonstration with this type of group rather than trying to rather than trying to teach them a slide deck, and it was a slide deck that was actually quite wordy as well. So we also provided train the trainer sessions. So this is a couple of the colleagues that I work closely with that were doing quite a bit of the training. These were the two main areas, community hospitals that I'd gone to, was Alwaj and Gizan. And meanwhile, back at the, I had colleagues that actually traveled the same time, and they actually were in a 5-star hotel over in Riyadh, which kind of surprised me because they had separated us, but it was all about I think the groupings and the areas of expertise. But I have to be quite honest, my rural experiences, and particularly with the individuals that I had worked with, this is where we had opportunities to actually see and visit a lot of the land. At the end of the day, we really did our best. There's still ongoing transmission. And sadly, the case fatality rate with this disease is 35.5%. So it's quite high compared to our first SARS. Now going into our current COVID-19 outbreak that we have, just quickly go through the timelines. December 31st, a pneumonia-like illness was of unknown cause was picked up, and actually studies are going back. A lot of papers and research is going back to even as early as August and September, where this pneumonia-like illness had first appeared. Just as an FYI, I'm not sure if anyone is aware or listened to the news around the COVID-19 World Health Organization, and there's a group that are actually over in China as we speak, in Wuhan, and actually doing some investigation. And at this time, the Wuhan officials are not going to release any of their lab information. So that's interesting that they're not doing that. Then in January 12th, if you can see sort of the timeline, here we are December 31st, in which they're first reporting it, and yet January the 12th, so less than 2 weeks later, they're able to give us a genetic sequence which allows countries to develop the specific diagnostic tests. Those usually take, I want to say, anywhere from, it's more than 2 weeks, but it's usually around 8 weeks at the minimum. And just to give you that sort of time span, with the first SARS or the first coronavirus that we had, this appeared in the fall of 2002. We still did not have sequencing into April, and that was when we, like I said, brought in the Stryker suit. Then January 30th, the World Health Organization declared it a public state emergency of international concern, and why they did that was to really help some of those under-resourced countries and to actually reach out and get some of those additional resources that are going to be needed in the event of their community having an outbreak. And then shortly thereafter, March 12th, this is where we declared it a pandemic. And when we look at the pandemic features, we take a look at where we're at right now, or currently. We're between phases 5 and 6, where we're still having that widespread human infection. And then as well, we're looking at even post-peak, some of our numbers, and as things are opening up, we could get into this post-peak period where, again, there's going to be this possibility of recurrent events. And as some of you may have heard or not heard, but there's predictions of a third wave, and particularly with our variant strains, because they're certainly a lot more transmissible. It takes usually 1 to 2 minutes of being in a room with an individual, whereas the current COVID-19 is anywhere usually about 15 minutes. So that's really quite concerning for many of our scientists. Now, going into the origins of this disease, like I had mentioned, was Wuhan. And in Wuhan, they have many what they call wet markets. And these wet markets actually have like things like turtles, snakes, fish, crocodiles, bats. So there's a number of these, and you can see how wet things are. And as a matter of fact, when they actually closed down this wet market and they had gone in and did testing, there was quite a large amount of COVID-19 that they found throughout the wet market. It wasn't isolated to one particular area. Now I want to speak to this animal, and I'm not sure if some of you have heard what this is, but this is a pangolin, which actually is thought to be the mixing vessel to transmit COVID-19 to the human population. This is a species that actually is, with its tragic status, this is actually one of the most trafficked mammal in the world. And apparently these are poached. There's 1.1 million pangolins that have been poached for illegal trade in the last 16 years. And this is something that is really becoming extinct. And it's used for traditional medicine and bushmeat. So this is where the Asian markets, it's really in demand because it is like a delicacy as well as used in traditional medicines. Now the next slide I have is taken from today's current numbers, and as you can see, it's not very pleasant. We're over 100, close to 110 million cases, 110 million cases, yes, and over 2 million deaths that are associated with this disease. So the case fatality isn't as high. They're looking at roughly around, depending on the area, but it's roughly around 3.3% fatality associated with this disease or this infection. Next, some of the pro bono work that I get to do and really enjoy is go to Kenya, Africa. And how this began was back in 2016. We had a student that had taken the infection prevention and control course that was offered through Centennial College. I'm one of the faculty there. And this is our student that came here, and she actually was given a grant to come and supported by many of our IPAC colleagues. And as you can see here, this was through Aga Khan University and the Aga Khan University hospitals. And many of the staff that came over to take this course were specific to the public health hospitals. And we actually had one student that traveled over 24 hours from Uganda just to take this course. And and again, these are underdeveloped countries, and it's certainly really rewarding to do this type of work if anyone gets an opportunity to assist other countries that are under-resourced. So I did a lot of train the trainer. We did left them with so many resources and, of course, the networking opportunities. And last but not least was their project. So they had to come with a project that they wanted to do. And I know earlier Leslie had spoken about, you know, the inequities that we see. And if you look at the photo on the left, and this here was one of the project works that one of the nurses had done. And just to be able to get running water, never mind it, and this was coming from tanks. Some days they wouldn't have the tanks to, or they wouldn't be able to have the amount to keep them all full. And as you can see here, infection prevention and control is really first of all, it's contaminated water. Second of all, you can see how grungy the bucket is. And then we've got the bar of soap. And then if you look at the photo on the right, where they had the project that they were able to do is actually get some plumbing in and actually get some potable water and a soap dispenser, which was amazing. And she was so proud of what she had. And this is our graduating class, and you can see here our first student that was also assisting us. And then what's going over to a country without experiencing a little bit of their Nairobi National Park, so we did get to experience. And then this is the last there was 3 of us that had gone over. We did, this is our 3rd time. This actually occurred February 2020, and believe it or not, we just arrived home before the COVID literally hit the ground running. So this was our students. We really enjoyed them, had lots of fun, fulfilling work, and especially knowing that you have an opportunity to provide the tools and resources to assist them just in some of the basic principles of infection prevention and control. Last but not least, I'm going to talk about the preventative health and health promotion. And like I mentioned in the beginning of my slide deck, I said preventative health and health promotion is really, when you look at what infection prevention and control is, this pie shape really goes into opportunities that it's a solid infection prevention and control program. And this is usually common in, for example, your hospital settings, particularly, as well as the amount of time that would be devoted to each of these areas would be based on the type of setting, the day, and even the hour. I'm sure many of you know that we're really spending lots of time currently right here in the disasters and pandemic. And then on a final note, what I'd like to say is for individuals that are reaching out that need information, for example, evidence-based, scientific, really go to the resources that really give individuals that richer amount of information, because that to me is more important, and you're really getting the truth and you're getting the information that is needed. And with that, I'm actually completed my session. Thank you.
Thank you so much, Barbara. Our next speaker is John Jackson. He's a registered psychiatric nurse and holds a Master of Psychiatric Nursing. John Jackson is also completing his PhD in nursing. Welcome.
Hey there, Melissa. Thanks for the introduction. It's great to be here today, folks. A big thank you to the conference organizers and University of Manitoba and Brandon University for facilitating tonight's session. So what I wanted to do today is take probably a little bit of a different approach when it comes to discussing health promotion and prevention. And that will be by talking about some ways that you can think about advocating at a systems level when it comes to healthcare, whether it's health, mental health, substance use related issues, and so forth. So just before I get into my slides, another thing that I'll share with you is, as a registered psychiatric nurse, I think advanced practice looks a little different. So I know that there's a number of psychiatric nursing educators in the room, a number of colleagues who are also taking their Master of Psychiatric Nursing program. And currently that's kind of where the opportunity ceases for registered psychiatric nurses. We might find positions as clinical nurse specialists. We can certainly work in administration and education and certainly do great things, but we're not able, for example, to enter a nurse practitioner program. And there's a few reasons for that. So I think talking about advanced practice can come from a slightly different angle for psychiatric nurses. So I'm just going to go ahead and share my screen. So what I'd like to do today is speak a little bit about some of my own personal experience in practice, and to share some ideas for you that I think you could apply when it comes to effective system level advocacy. Just being a 15-minute presentation and being sensitive to the time, I've kept it pretty brief. And I'm going to base this, as I said, on my own personal experience. So specifically, one thing that we're proud of for the community of Brandon is that between 2018 and 2020, we were able to make very significant enhancements to our homeless shelter. So I'm going to use the presentation to talk a little bit about that process and hopefully kindle some ideas for you when it comes to sort of advocating at that systems level. So when I think of myself and when I think of the many people I know who have pursued advanced education in nursing, we're typically doing it for a few different reasons. One of the reasons is that we like to learn and we want to continue that lifelong process of understanding and gaining new knowledge. Others among us may wish to do certain things which you can't do unless you have a master's degree or unless you've pursued a PhD. And I think for both of those groups, and additionally for other folks, we're interested in pursuing that type of education and those types of positions because we want to make changes and we want to improve health outcomes for individuals in our communities, in Manitoba, in Canada, and around the world. So I believe that one of the key functions of advanced practice nursing is advocacy. Whether we're advocating for individuals, whether we're advocating for communities, whether we're advocating for provinces, and so on. So I'm going to keep it short and I'm going to talk in metaphors. For those of you who know me, I kind of like my metaphors. So let's talk about a sort of three-pronged system when it comes to advocating for system level change. The first thing I suggest you want to do is look for the treasures. And what I mean by that is identify the right opportunities to make changes. And we'll talk a little bit more about what I mean when I say that. Secondly, how can we take a bird's eye view? So take a bird's eye view. Think about how a problem is interrelated in your community. We want to sort of look at it from a high level. And my little Zoom box is covering up my slide here. And then thirdly and finally, don't stop at the clearing. So if you've got that machete out and you're hacking through the bush and you've made yourself a path and you finally get to a point where you've had success, we're not going to stop. You're going to take the success that you've had and you're going to continue seeking new successes. So I was the executive director of a group called Samaritan House Ministries in Brandon, and among a wide variety of services, some of the key things that we did was our food bank, which distributed about 2,000 hampers in the community of Brandon each month. So a community of 50,000 people were giving out about 2,000 hampers. And another one of the main projects that we operated is our Safe and Warm shelter. So if we're thinking of things that we want to change in the world, there's so many important things that we can commit our time to. And what I should clarify and what I should make clear is that everything and anything that we as individuals choose to turn our attention to and try to improve and change is worthwhile. And there's certainly no such thing as more important or less important problems. In this context, I'm thinking about things which we might be able to solve quickly or in a fairly timely way. So the world is full of problems, and many of them are what we call wicked problems. So wicked is a term that basically means there's complicated reasons for the problem, and there's no one solution. if we're thinking of areas where we want to make good gains over time, we should consider problems that are of interest to stakeholders and decision makers. So considering problems that are of interest to stakeholders and decision makers. And consider problems that appear like they may be feasibly addressed. So just to give you a little bit of context, food insecurity is such a massive issue in Manitoba, and certainly we have some of the highest utilization numbers across Canada. And yet at the same time, there's a lot of barriers to improving services in the food bank world. Some of those might be seen from a business perspective, that there's a lot of financial investment that could be put into issues of food security without necessarily resolving some of the root issues. And so what I perceived in my experience, and I'm just speaking from my experience, was that the timing wise, there was less collective interest in making significant changes around food bank utilization than there was with our safe and warm shelter. So something that might surprise you, it certainly surprised me, is that, you know, a shelter in Western Manitoba in which, you know, we have -50 and in which the weather is not good through till, you know, May or June sometimes. The shelter's only open for a certain number of months of the year, and we had a very limited number of beds. So to me, this appeared to be a problem which was of interest to a variety of stakeholders and decision makers. And so it seemed to me that this was something that we were going to be able to resolve if we put some work into it. So I picked something that I perceived we could make some ground with. So we need to take a bird's eye view of the problem. And as nurses and helpers and caring people, so much of what we do is one-to-one, and that work is very important, and that work has to continue. And yet at the same time, there has to be those of us who are thinking of things from a big picture perspective. So we may be tempted to consider problems from an individual perspective, and that certainly gives us context, and we can't lose that. And yet at the same time, we have to step back when we're thinking of advocating for these changes and think, okay, how am I going to get buy-in here? So one way that we can do that is try and determine, is there a diverse group of stakeholders? So lots of different people in different sectors, for example. So using the term intersectoral, who have an interest in seeing this particular problem solved. So it goes without saying that in our healthcare community, counsellors, health access centres, regional health authorities, they want to see options for folks who are living with housing insecurity, no doubt. Who else is interested in trying to find a solution for that problem? So in our experience in Brandon, we saw that the police service was also interested in making sure that folks weren't stuck on the street overnight when it was very cold. We saw that, you know, various child and family service groups were interested in this. We saw that faith groups, churches, congregations, universities, colleges, a wide variety of folks and stakeholders from different sectors all were interested in seeing this problem solved. And those various folks, those various groups who were involved in providing services for people living with housing insecurity would see a benefit or would see an improvement, not just in the lives of those people, but also in the way that they were able to offer services. And so, as I began speaking in the community of Brandon about the need to expand shelter services, the need to extend the length of time the shelter was open, so on and so forth, I was very intentional about seeking the involvement of those different stakeholder groups, asking their opinions, providing them opportunity to let us know what would be helpful, and so forth. And the largest stakeholder group that I have neglected to mention, not intentionally, are the clients who have been using the Safe and Warm Shelter service. So, long story short, as a result of speaking up about what was happening, finding that right opportunity, seeking involvement from the right groups of stakeholders, figuring out how a solution would help many different groups involved and so on, an opportunity came forward from the City of Brandon, who provided financial investment. Opportunities came forward from, provincial government departments and so on. And we were successful in getting the Safe and Warm Shelter in Brandon expanded. And then ultimately services increased, although not year round. And then unfortunately, of course, as we're all aware, coronavirus occurred and things changed a little bit. But once we had that success, once we had folks come forward to help us in a financial way, increased volunteer hours and so on, didn't want to stop at that. It was important to the organization, to the community, to myself, to try to think about ways, okay, so we have a place where people can be safe, and that's great, but at the same time, it's not necessarily providing solutions for some of the root causes of why folks might be experiencing housing insecurity in Brandon. So we didn't stop there, we kept going. We presented to the City of Brandon, we presented an idea of basically a street outreach program where we would be approaching people in a respectful and suitable way and speaking about their reasons for being on the street, trying to determine what they need, connect them with resources and so on. And Samaritan House Ministries was granted funding to execute that project. So we don't stop, we keep going and so on. Think about situations that are related to the success that you've had and how you can apply the success to another issue and keep on pushing on. I'm not sure if the slides will be shared or if the recording will be accessible, but another thing that was important to the organization at Samaritan House was positive relationships with the media. So again, they sort of developed a hierarchy of making the community aware of what we were doing, keeping the community in the loop when we were successful in expansion, keeping the community in the loop when we were successful in keeping the shelter open longer, and so on and so forth. So it's important to stay relevant in that way. Just as I end my presentation, I'm just going to stop my screen share for a moment here. Is everything good? I just see the little message in the chat there. There's many problems in the delivery and the network of healthcare and related services, not only in Manitoba, but all across Canada. And I think it's really imperative that nurses, psychiatric nurses, and really a wide variety of healthcare and non-healthcare professionals pursue the education they need, attain the skills and experiences they need, and apply their smarts to tackling some of these problems. I speak of treasures and looking for problems which might be easily fixed. And I think there's a number of them, even here in Manitoba, for example. We have a lack of parity in the types of healthcare disciplines that are providing services in one RHA versus another. I think that's a fairly easy fix. And then another problem that I know many are committed to working towards is legislated advanced scope of practice opportunities for psychiatric nurses, which would include buy-in from regulatory colleges, buy-in from legislators, buy-in from educational institutions, and so on. And it may not just be in Manitoba. It may be that the provinces of BC, Alberta, Saskatchewan, and Manitoba have to work together. But I see that as a doable thing. So hopefully that gives folks some ideas and inspires people and helps us to move forward. So thanks so much for the time, folks, and I look forward to chatting and answering any questions when we have our discussion.
Thank you, John, for an excellent presentation, and also for kind of broadening our horizons and to see that what a nurse can do. So moving forward, our third speaker, Lea, is a clinical nurse specialist with Population and Public Health Program of WRHA. She uses her Indigenous ways of knowing and with the focus of Indigenous health equity, and provides clinical expertise to guide public health nursing practices in the area of healthy parenting and early childhood development. Welcome, Lea.
Thank you. Can you hear me okay?
Yes.
Okay, perfect. Okay, I'm going to share my screen, I think. Okay, so I'm a contrary, so of course it had to start at the end. Okay. Okay, I hope you can see that. So, Kwe, Uchalasi, Mi'kmaq Nani. I just want to thank you for inviting me to participate tonight. As you said, my name is Lea Mutch. I'm a clinical nurse specialist in public health, and I support the Population and Public Health Program and public health nurses working in the community areas of Point Douglas, Inkster, and in Churchill. And I also have a role as a program specialist in Indigenous health. I'm also a graduate of U of M, both I did my bachelor degree there and my master's degree there. So there's that. So I'm going to share how I'm working towards reclamation of health as Indigenous people from an Indigenous perspective. The first word in the title of this presentation is Ali Kanej, meaning let's walk together, which is the way that I approach the work that I do, and which is what I invite you to do with me tonight as I describe some of the work that I've been involved in. Wileg is a concept that is a Mi'kmaq concept around wellness, and it's not just about healthy or health or being healthy. It also means that you're living well or living a good life. This is a First Nations learning model, but I like it as it depicts living well. So if you look at the center of the model, it has collective well-being, which is very much an Indigenous perspective. We tend to see our worldview as collective rather than Western worldview, which is more individualistic. But even if you look at it at an individual level, you can see that living well means it encompasses many things, such as our relationships with our relatives, with our clan and our communities, and our ancestors. To live well, we must have a connection to the natural world and to our languages, because that is what connects us to one another and to our ancestors and to our Creator. I just want you to remember these things because it's a different way, it's a different than Western perspective of health and well-being, I think, and also because I will be talking a little bit about this in the context of the current status of the health of Indigenous people. So I told you that I work in Point Douglas, or I support the Point Douglas public health team, and there's a large Indigenous population in Point Douglas, so I kind of just picked that community. And as just an example, these rates can be seen across Canada, of course, and throughout Manitoba. So looking at Point Douglas specifically, they have the highest death rates in Winnipeg in the region. They also experience the lowest life expectancy at birth, And there's about a 20% difference between life expectancy from this community that has lower income than another community that has the highest income level. So you can see that disparity in income plays out in other ways in health. During 2002 to 2006, there was nearly a 17-year difference in life expectancy for females and almost 14 years for males between the two community areas. Living in Point Douglas also means that you're twice as likely to die before you reach the age of 75 than if you lived in another neighborhood in the city. They have the highest infant mortality rates, highest child mortality rates. So for example, in comparison to Seven Oaks, which is another community area, they had 9.3 deaths per 100,000, and Point Douglas has 55.5 deaths per 100,000 children. So that's quite a significant difference there. Also highest for chronic disease, all the chronic diseases, and mood and anxiety disorders. And suicide mortality is highest among those between 45 to 54, 4.3 per 10,000 versus 0.8 per 10,000 in, I think it was Fort Garry. And when we look at COVID-19, because we were talking about that earlier, the COVID-19 rates, positivity rates in Point Douglas are quite high. I think they're around 50% or 52% right now. I think it's important to look at some of the history and particularly the legislation that has impacted Indigenous health and still impacts the health of Indigenous people today. By 1867, the government recognized that they were going to have to manage what would be called the Indian problem. So from 1871 to 1921, they enacted several treaties that were signed between First Nations people and the Crown. But the most racist and damaging piece of legislation in Canadian history is the Indian Act, which came into effect in 1876. This legislation was and is grounded in racist ideology that assumes that First Nations people and their way of living and knowing are inferior to Western ways, and that First Nations people were really uncivilized. So the goal of the Indian Act really was to go about what they would call civilizing the Indian. Part of how the government sought to civilize First Nations people was through the Indian residential schools, which operated for more than 160 years and had 150,000 children pass through that system. With the residential schools came the removal of children from their families, from their communities, from their ancestral lands, from their languages and their ceremonies. So when we think back to Wilig, which is living well, and all of those components of living well and having a healthy life from an Indigenous perspective, that disruption in family, community, language caused a lot of harm to Indigenous people, to First Nations people, and all Indigenous people in terms of living well. Canada is one of the only nations in the world that continues to use legislation to limit access to services and benefits for Indigenous peoples. The Indian Act has resulted in the development of institutions or systems that have allowed the entrenchment of racism into the policies and procedures of organizational structures that affect life and well-being of Indigenous people, including education, justice, governance, and economic development, and the healthcare system, which really all create barriers for Indigenous people to live well. I took this directly from the Canadian Nurses Association, and I just want you to sort of note the second line of this statement. It's their position statement. So as a leader and agent of change, the CNS influences clinical practice and political processes throughout the healthcare system. So I think it's important because often we do think about, you know, our role as clinical leaders and that clinical piece, and well, that's important, and I do that. I'm also thinking I have a much bigger responsibility in that I'm expected to be a catalyst for change. So if things are going to change and someone's got to do it, so it might as well be me. So I'm a big advocate for that, and for nurses really thinking beyond, you know, beyond the clinical piece. And as the previous speaker said, look at the bigger picture. So this is from Population and Public Health. And this is what we do. We work with individuals, families, communities, and partners, and we really are there to promote health and prevent disease. We do have a health equity position statement, and within the WHA, and if anyone is really interested in reading it, you should. It's quite an interesting document, and it really acknowledges that gaps in health exist, and that Winnipeg has some of the largest gaps in health equity in Canada. And it recognizes as well the impact that colonization had on the health of Indigenous people. So looking at that, that was kind of like something that we have that we can, you know, sink our teeth into a bit, because we have this position statement. So one of the significant impacts on the health of Indigenous people is racism and the experience of racism within the healthcare context. Broad power inequities have both direct and indirect impacts on Indigenous health to serve to reinforce anti-Indigenous racism inside and outside the healthcare system. Specifically, Indigenous communities often receive less funding for health services and basic needs in non-Indigenous Canadian populations. Indigenous people are often blamed for the circumstances that are linked to poverty that are imposed by settler colonial systems. Western biomedical knowledge continues to dominate the healthcare system. High quality, ethical, population level health data on Indigenous people is lacking. And people who are in positions of power and are the decision makers often have a vested interest in maintaining the status quo. So my position is that as long as we as a healthcare system continue to be harmful to Indigenous people, we really cannot begin to be effective in promoting health. So these are some of the things that I've been involved with. So what we have is we've created a think tank, which we called Closing the Gaps in Indigenous Health. There are 5 members of the group. The numbers kind of, I don't know, change sometimes, fluctuate, but it's been pretty consistent. 3 of us are Indigenous. And what we do is we come together and we put forward a number of strategies to address racism within our program and try to influence the system and the region and other systems. So one of the things that we've done over the past, I'd say 5 years or so, is we have extensive training for staff. So one of the things is having a half-day staff development session that focuses on racism, specifically anti-Indigenous racism. We also have required readings that we do quarterly, I think. And those readings, they're not just readings, but they could be something that we watch. Or one time we went to the museum and did a tour of the museum, and then you have a discussion and a debrief about it. We also have used the Manitoba Indigenous Cultural Safety Training, which is mandatory for all public health staff. We have it within our region, but not all programs. I mean, people take it, but it's not mandatory, and it needs to be. We also review policies and guidelines and things like that using an Indigenous lens, and a lens that really is trying to reduce harm to Indigenous people. So for example, there were recently a couple of modules, LMS modules, that were, one of them was around abuse and neglect, and one was a home environments module. And so just looking at those, and they were quite harmful. Some of the language in there was harmful around children, and, you know, this is going on, just called CFS, which is very harmful to our people. So we were able to look at that as a group and to take some of that feedback forward and push kind of hard, give a hard pushback and have that changed so the modules are less harmful. I've really been involved with creating a representative workforce. So we have Indigenous designated positions within public health. We don't have many. If I have anything to do with it, we'll have a lot more. But we do have positions. So I've worked closely with the union and with human resources, and leadership really has been supportive. So that's one of the other things that I've done to try to shift things and change things. Because if we know that if we have a representative workforce, then Indigenous people are going to be safe for our Indigenous, the people that we work with. We also have partnered with some Indigenous community-based organizations, Aboriginal Youth Opportunities. We had a partnership with them. Mamaway, we've partnered with Ganiganichuk, we've partnered with, because they have the credibility in the community, and they do the work and they know how to do the work. And so really, if they partner with us, we're just blessed because we learned from them, and they're our leaders. And so that's who we want to partner with, are people that will show us how to do things in a good way. We've also looked at development of an anti-racism policy. Initially, it was going to be a program policy, and then it went to the region. And now I don't know that it was ever approved, but I think now it's at Shared Health waiting for some kind of approval. So it could be a provincial policy, which would be good. And the other thing that we did was implementing the TRC calls to action. The calls to action came out, and I mean, we realized that people would look at it and go, oh, this is really great, but what do I do with this? So what we did, we worked closely with Indigenous health programs, and we developed a half-a-day workshop for leadership. So it was all the directors, CEOs, all those people. And they attended a half-a-day workshop and came up with strategies themselves on how they could implement the TRC calls to action. Some of the barriers I think that we faced are just, you know, sometimes people in power want to maintain that status quo. There's definitely been resistance here and there when we've done workshops around anti-racism. And just that denial, you know, it doesn't exist here and everybody's gets along and we're all great. And so there's just been a bit of that reluctance and resistance to change, I would say. Also having a workforce that's underrepresented has been a barrier, because it's hard to get traction when you don't have the people that represent the community around the table. So often it's like I might be the only person around 20 people that's Indigenous, and I'm trying to advocate for things. And so that can be a little bit of a barrier, I find. And then sometimes when you are there, you get that tokenism, and you're there as a token sometimes, and that's not the greatest. So that's another barrier. And then there's this sort of this multicultural approach that people seem to want to take. And that's sort of when, you know, it's sort of like, well, if we understand the culture, then everything's good. So instead of looking at racism and looking at those tough issues, they will say, well, let's do teachings around, you know, if people know what a sweat lodge is, and everybody's going to be culturally safe, which is not necessarily true. So, and that also puts the onus on Indigenous people to fit in or do a better job of explaining themselves and that sort of thing, and healing themselves, and, you know, it's our problem rather than it's a racism problem. Facilitators that I've had have been, I've been blessed to work with great Indigenous leadership. I work with Marcia Anderson, who is awesome, and that has helped. I mean, without her, I don't think we would have gotten half the stuff done that we have. Also having leadership, the leadership I work with has been good. They've been very supportive. Sometimes they don't get it, but they try, and, you know, eventually they come around. They might not get it first thing, but they listen, and then they usually come around. Working with others who, of course, who are supportive. Some of the other people in public health have been great advocates and great allies. So we couldn't do this without them as well. And then of course, working with other Indigenous nurses who we have a bit of a support system in place because there's quite a few of us now, so we have each other's back and we support one another. So going forward, I think cultural safety and healthcare should be mandatory for everyone, and not just that, but we really need to have peer support networks where people can take the cultural safety training and then they can have a place where they can debrief about it and talk about it and work through it and learn how to apply it to their workplace, because so often, you know, you do the training and then it's like, okay, now what do I do with this? And then people kind of just forget about it. So I think it would be good to have peer support networks. Also having organizational level anti-Indigenous approaches, anti-Indigenous racism approaches, I should say, is something else that would be recommended. So when we're looking at strategic planning and those sorts of things, those large organizational initiatives, having accountability and some kind of monitoring and evaluation of people in the healthcare system so they can't just do racist crap and get away with it. Having a safe work environment for Indigenous staff so that we retain them. Most Indigenous staff quit their jobs not because they hate their work, but because their work environment is not safe for them. It's not a safe place to be. And then working across other health and other sectors. So trying to influence other programs, we do some of that. And we also, I would say working across other sectors, like working with the child welfare system, for example, has been something that I've been involved with recently. So that is kind of it for me. I just want to say that, you know, I have been trained and educated in the Western ways, but I approach health and well-being from an Indigenous worldview. And so for many Indigenous people, it's difficult to walk those worlds, those two worlds that we have to walk between. It's not an easy thing. I think anyone would agree with that. And I just want to say that for me, this is not about decolonizing. We talk about decolonizing and indigenizing, you know, we got to indigenize our curriculum. For me, it's not about that, because that's the systems that we have, the education systems that we have are colonized systems. And I don't think that's really what we're doing. I think what we need to do is reclaim our space as Indigenous people. And our ancestors knew how to be healthy and they knew how to live well, and we carry that knowledge within us. So we need to reclaim that. And I think for other people who are non-Indigenous, other healthcare providers and others, if they can give us that space and let us take that space and shift the systems that need to be shifted so that we can live well and live a good life, then that's what we need to do. So with that, I will end this presentation. Thank you for being a good audience, although I guess you don't have a choice because you can't really say anything back.
Thank you, Lea, for your excellent presentation. Our final speaker, Rachel, is a nurse practitioner and instructor at the University of Manitoba and a clinical preceptor for nurse practitioner students from a variety of Canadian universities. Rachel also works in primary care services in Southern Health Authority. Welcome, Rachel.
Thank you. Thank you so much for having me, and thank you to the other panelists. That was very stimulating and motivating. It's great to see where all the advanced practice roles can lead us, and it's nice to have different visions and viewpoints so we can build on each other's insights and knowledge. I'm going to share my screen here. Okay, so I'm representing the nurse practitioner stream of this presentation here, this forum, and here's my shameless plug for the Nurse Practitioner Association of Manitoba. So I would say, I assume most of you are are probably already nurses or in your master's programs or advanced beyond that. And if you are in those nurse practitioner streams, I would strongly recommend that you do become a member. It goes a long way to advocating for our profession to continue to grow. So there was an acknowledgement at the beginning already, and I have no other disclosures. So nurse practitioners tend to follow the STRONG model. In the WRHA, the nurse practitioner role is built off of this, which is really 80% is in direct comprehensive care, and the other 20% is divided between a variety of other areas here: supportive systems, education, research, and publication, and professional leadership. For the purpose of this presentation, I'll focus mostly on the direct comprehensive care and maybe how those other pieces are woven into that. So although I work in 2 clinics, I'm predominantly at the PCI teen clinic in Portage la Prairie. And so I'll focus just on this one for now, although I do cover all ages at the other clinic that I work at. This clinic is built for the demographic ages 12 to 21. So that's the majority of the people I see at this clinic. We do have a multidisciplinary team and a very great team to work with. We have a public health on site, dietitian, Addictions Foundation, and Manitoba counselors, and adolescent and shared care clinician is on site. And now we have the new development of enhanced mental health and addictions team that also has a psychiatric nurse. So we have that on site. That's new this year in a pilot project, and we're very excited about that. So we're focused on strategies for preventative health and health promotion in the adolescent population specifically. And what does that look like in the nurse practitioner role as well? So I'll just talk very briefly about a few of the common presentations and how we need to just reevaluate that when they come into clinic. So in terms of sleep, sleep is a huge issue in youth, and this is for a variety of reasons, but with the changing hormones, there's also a natural shift of the circadian rhythm, and so there's a natural inclination to stay up late and sleep in. And on top of that, there's very busy schedules, right? So there's schoolwork, there's jobs, and other social activities or sports or other organized activities that they're participating in. So you get a lot of vague complaints when you have people presenting into clinic. And so now this is where I kind of appreciated Leslie's perspective in that social justice piece and kind of looking a bit broader than somebody just coming in and what are their symptoms and are you just going to talk about sleep hygiene, which is extremely important and very underutilized. But maybe we do need to look at some of those other social factors. Do they have a safe home? Are they couch surfing? We do have a homeless shelter in Portage la Prairie. Are they using that? It is open to youth. They don't have to be 18 to use it. And so I'm so excited that that got started. So at least there are safe places to sleep instead of maybe on the roof of the school, which has happened before too. So although we go over this, it's every time a youth presents with something, we always do want to take that big picture. Are we addressing all the needs and all the barriers to them getting that sleep? Because it's so incredibly important for their ability to function, their ability to complete their studies, to complete their high school requirements and graduate. Even the understanding around substance use like caffeine. There's a lot of youth that will come in with symptoms of anxiety, palpitations, but here they haven't been getting enough sleep and they've been supplementing with caffeine, and then that makes them completely non-functional a day and drives up the anxiety for them too. So every time a client presents, we're always thinking of that holistic picture. We're always bringing in preventative health care. I don't think there's a client that comes into my clinic that I'm not doing some sort of healthcare discussion or prevention conversation with. Diet is huge, and the ability to, there is eating disorders in youth for sure. That's an issue, but there's a lot of disordered eating patterns, and when that comes into the clinic, we really have to think, why is that happening? Is there, are there self-esteem issues or weight concerns? Is it a food access issue? And what else is going on? So in young women especially, iron deficiency is quite common, and iron deficiency with or without anemia. So that's something we need to follow up. These young women are doing an incredible amount of growth. They are losing a lot of blood through their menstrual bleeding, and their diets are often insufficient to compensate. And so we need to pay attention to that. And do they have enough food to replenish those iron sources too? Do they have access to high protein foods? And so this is one place where I appreciate John's point there too, in just looking at gaps or challenges kind of in a broader perspective. So here we did find a gap, and we did find that food access was an issue for youth. And this motivated us to look a little bit broader and determine a process where we could work with a lot of our stakeholders, with the school, with the community groups, to find food for youth. So youth that had food in their homes, their disordered eating patterns might look like the choice not to have breakfast or lunch and then just eat at home in the evenings, whereas other youth would have no food access at home. And so their only food access in the day was what could be arranged through breakfast programs or school lunch programs. And so we really had to see what are those barriers, and we developed plans and guidelines so that we could have special permissions and access different community supports to make sure that if food access is an issue, that was available for the youth. And we need to be mindful of calcium, vitamin D intake, of course. If I support any supplement use, it would be more in omega-3 and vitamin B12 as opposed to caffeine and nicotine. I think those are much healthier boosts to the system. And of course, the overwhelming, I think we should all probably be on these low FODMAP diets for irritable bowel syndrome. It seems like this is almost endemic in our society, and I'm not sure why that is, but those kind of vague general abdominal complaints are a very common reason why youth don't complete their school, completely don't complete it. They don't graduate because they feel sick every day, and that's a very big issue. And so I think kind of exploring this in practice and bringing more awareness to this topic is very important too. So if you're not familiar, I mean, the low FODMAP is a diet low in fermented oligosaccharides, disaccharides, monosaccharides, and polyols, which are those simple sugars that are very difficult for our bodies to digest. And so the bacteria within the gastrointestinal system tends to feed off that, causing bloating, water retention, and pain. And that can also trigger your enteric nervous system. So we get this a lot with youth who then have a bit of nervousness coming into school, and then they have these types of symptoms, and it kind of feeds on each other, and they end up going home often in the day or not coming in at all. And so you really need buy-in from youth and from their families to understand this process, but this can be life-changing, and it has been for a lot of people to get their lives back if we address some of those issues. And then we also have to think too, right, if food access is an issue, the types of foods they have access to might only be foods that are high in those FODMAPs, and so then you have that vicious pattern that's happening. So in terms of mental health and mental health supports, generally in terms of so health promotion, and we're looking at social connections, and through school groups we can have that. We're also looking at the effect of substance use and really focusing on risk reduction and stress management for youth who are juggling so many things at once. There are services available there, and I put them there in case you needed some resources for youth, and those are some mental health virtual therapy programs. As well, the youth really like apps, something interactive, and the ones that I recommend the most are one through Anxiety Canada called the MindShift app. That's a really serene looking face there. And Clinic with a K in Winnipeg has Calm in the Storm app. So those are excellent apps to be used for youth, and it gives them skills in the moment that they can use, whether it's test anxiety or sleep hygiene. It's a great resource that way too. And then also through Teen Talk and CERC, they did release this youth mental wellness booklet that we can download or give out as well. And it just also goes more in that preventative healthcare. So I don't necessarily want to go into treating diagnosed mental health conditions here, but just how can we help to kind of support more resilience mindset. And also in that regard too, with these school groups, they're really fantastic. And if we think of who are the stakeholders we're involved with, it is the youth, predominantly, that we want to go to first. And that's one way where I want to change my practice too, in terms of, and we started consulting with different groups that are already active in the school, such as Sources of Strength, the Youth Chief and Council group, the Queer Straight Alliance group, and all of those groups are already actively involved. So I think it's just a matter of connecting with them to say, are we giving you a safe space? Are we giving you a good location? And how can we do better? So in terms of reproductive and sexual health, this also was a big part of our role in Teen Clinic. And even the basics of just hygienic health, going through those basic conversations every day with youth. What does that mean? How do we prevent, how do we prevent urinary tract infections and candida vaginitis and bacterial vaginosis? Those are conversations that we have all the time. What are the resources we can give them? I really like some of those resources and information through Women's Health Clinic. If you look under their resource page, they have excellent handouts and places, things that you can review with youth. They may not always want to walk out with a piece of paper, but I like to direct them to reputable websites to find their information. One thing that we're working on now quite actively, and I think this is what John was saying, where you don't stop at the clearing. And I've been in, this clinic has been running since 2008. I've been here for probably 7 or 8 years now. And you kind of get comfortable, right? You think, okay, everything's working okay, we're doing everything well. But I think it's always good to be vigilant and to see how can we change and improve. And there's definitely a gap in our ability to provide gender and sexuality affirmative care. And especially we didn't have any sort of supportive options rurally. It's all in Winnipeg. The only thing we can do is if you have any questions or any needs, really you have to go to Winnipeg. So an exciting development in the last year was that we have a physician that came into the community that did start his own gender and sexuality clinic to also be able to go through different types of treatment options rurally. And so we're actively working now getting all the stakeholders involved to allow for some on-site time for him in the PCI teen clinic specifically, so that he can come at least once or twice a month for those that are getting care, and make sure they have a place to come to do some of their initial consults, and we can do follow-up there too. So I'm really excited. We're finding other ways to kind of augment and enhance the supports at the teen clinic. And it's just an excellent way to do that, and to collaborate with with the resources in the community, with our stakeholder support as well. So we're also looking at barriers in any of these issues, whether it's barriers of access, which is why we're located right in the school. Finances can be a barrier too, in terms of what we can supply. Confidentiality, we're very clear on that process too. We want that to be a safe space. I'm in the Southern Health, Santé Sud Regional Health Authority, and we have the great benefit of having a public health program that does provide a formulary for contraceptive management for those with financial needs, where it can be covered 100% for them. And this is fantastic. So if we think even in the advanced practice role, I've been active on the reproductive health committees for our region, and also supplied the research to have the Kylina intrauterine system added to that formulary as an option for the youth, which is fantastic and life-changing, and it can get a lot of the youth through their post-secondary education as well. So it's been a good uptake there. So also with sexually transmitted and bloodborne infections, we're looking at those types of prevention and health promotion. Then we're looking at different risk reduction, barrier protection, and routine screening. So another way we decrease those barriers to care is nobody will go to the lab if I provide a requisition. That just won't happen. And so we provide all testing on site, and that's to decrease those barriers and make sure that we have an open access concept, so that we can do those follow-ups with youth and make sure that they know how to take care of their health that way too. And then of course finding them resources. So a lot of direction to the sexandyou.ca website is an excellent resource for them as well. So I think in the nurse practitioner role as an advanced practice nurse, yes, we provide direct comprehensive care. I think with our nursing background, we also we're in a really great position to incorporate preventative health care in every visit that we have, which is a great way to provide health care. And then if we incorporate the other systems there, the supportive systems, publication, leadership, research, education, we're accessing those all the time when we do find those gaps. And how do we consult? How do we collaborate? How do we provide research to support changing the status quo and changing the way we're doing things to enhance our services, to enhance the type of healthcare that we are providing for youth? So whatever role you're in as a nurse practitioner, you have that ability to look larger, and even though we are giving direct care, but to really focus on those gaps and how to improve health for all. And I do have a list of resources here too, if you want to take a picture of the screen or something too, just so that you have some of those resources. These are great for youth. They're excellent, and I use them often. So yeah, that's where I'll end. Thank you so much for having me.
Thank you so much, Rachel, and thank you for sharing resources for all the different areas of health promotion that you work in. So with that, we would like to thank all our speakers for sharing their experiences on preventative health and health promotion. We do have a few minutes to answer some questions. So just a reminder to please use the Q&A function to ask questions. I do have a few here to get us started, and they are for all of the panelists. So feel free to just unmute your microphone if you'd like to answer the question, and hopefully we can get a discussion going. The first question I have here is, would you be able to comment on the biopsychosocial model of health as it relates to the health outcomes of patients and colleagues?
So I wonder if I can speak to this briefly, but I'd love to hear the other panelists' input too. So if we're thinking of that model, we're thinking of the biological, psychological, and social influences. And I think I touched on those in every area that I had. You had to consider those. And I would also challenge that maybe we should add a biopsychosocial spiritual model, or maybe something more in line with what Lea was talking about before in that Indigenous learning model. I think that was a fantastic a fantastic view of how we can be offering health services and what that means. Because certainly if I have somebody on site and they're not sleeping and I say, well, just try some sleep hygiene, but I don't know if they have a bed, then I'm not, nothing's really going to help them. And so I think, especially in where we're providing direct kind of primary care, we need to see the full context of a presentation.
Thank you. And any other panelists like to add on to that? Okay. Another question we have is, how do you build your confidence to become a successful leader? What are some recommendations you would suggest to build your network?
Yeah, I'm happy to jump in on that one. I think you have to be really intentional about it. And you need to pursue both formal and informal leadership opportunities. So, I mean, everyone can develop and build the skill of leadership. So informal would be, accepting opportunities to speak, making presentations, offering, your services or information to folks. And formal would be, pursuing leadership roles. When I was interested in leadership in healthcare, there was a particular position I was going for that I eventually got in a unionized environment, but someone had more experience, so it took a bit to settle that role. And some advice I was given was, even retail leadership experience, some formal experience in which you're a leader and you're developing managerial skills. And then in terms of the networking, we all sort of meet those people in life, whether they're professors, instructors, fellow clinicians, whatever it is, who we just kind of sync with. You've really got to jump to make that connection with people. If people are reaching out to you and saying they'd like to get to know you better or work together, as much as possible, accept those opportunities, and it just sort of starts to snowball from there.
Yeah, I agree with John completely. I think finding opportunities where you can be a leader, and it can be in so many ways. I mean, it can be with your kids or whatever, or in any way, like at a kids function or something like that, and just getting that experience. Like, I think being on this association is a really good example of taking a leadership role. And I know that in nursing, we often have practice councils. So if you can get involved with that, or union work or anything like that, is a good way to get some leadership experience. And really look for mentors. That's what I have found. So I've been lucky that I've had some really good mentors, and that has helped. And finding people that are really like-minded. And if you find that person, it's like, hey, this person, really gets it, and I feel the same way, and I think the same way, then just really building on that and building those relationships.
I feel like while we are waiting for more questions, I'd like to welcome Sherry, Executive Director at Shades Winnipeg, to highlight the important work Shade is doing. And this is a charity that GNSA is supporting along with this year's APN conference. So welcome, Sherry.
Hi, I can't start my video. The host has stopped it.
Just give me. You able to start it now? Okay.
I'm here. Thank you everyone for having me. It's been really, really good to hear everything. I didn't think I was going to. I thought I was going to be right at the beginning. So I am lucky because I get to also feed in on all of your knowledge. So I'm happy. I do have a very, very short PowerPoint presentation, so I'm going to see if I can share it right now. Where is it? Oh, goodness. And I don't see it. So where is it? That is really weird. I don't see it here. So let me go in, and I apologize. I thought I had it all set up. Trying to see if I can find it here now. I know exactly where it is on here. PowerPoint. Okay, can you see it now?
No, we've got your file screen up.
Okay, so I cannot see the shared screen. Hold on. Share screen. Okay, I think I have it. Can you see it now?
Yep.
Okay, awesome. Very good. Okay, now I just need to minimize my screen. Okay, good. Sorry about that. Okay, so this is our logo. SHADE is an acronym that stands for Safe Housing and Directed Empowerment. And the picture you see here is representative of the demographic that we are serving, which is immigrant and refugee women who've been impacted by domestic abuse, whether that's intimate partner violence and or family violence. Okay, so what we do is we are a registered charity. We've been a registered charity since June of 2017. We are working to provide second stage housing for immigrant women We don't have this safe housing facility yet. However, right now we are waiting for a grant from the City of Winnipeg. Hopefully we'll find out by the end of March if we have that, and then we're going into even further higher gear. Our vision is that women and children will be healed from the impact of family violence through the three-pronged method of safe housing, psychosocial counseling, and practical supports. We are offering the latter two right now. And the reason that we're doing this is we believe that given the right services and resources, we're going to witness incredible changes back to wellness and leadership in our community, so much so that generations will be impacted. That is the goal. And I did get into this because I am a survivor, thriver, overcomer of intimate partner violence myself. So in 2019, there were 18,000 domestic violence calls received by the Winnipeg Police Service. If you have a calculator handy, that works out to 49 per day here in the city of Winnipeg. I've spoken with Detective Shane Weprick, who heads up the DV unit of the Winnipeg Police Service, and they don't have the 2020 stats yet, but I suspect that they will be even higher because of coronavirus and women having to stay within the confines of their own home because of the health directives. Every 5 days in Canada, a woman is killed by her intimate partner, and that stat is becoming old. It might even be as low as every 2.5 days. And we believe that no woman is too insignificant to let her continue to stay in an abusive home situation because she thinks there is no way out. So during the past year, it has been very important for us to make sure that women, especially women who their first language is not English and they lack the knowledge of resources and services that are available to them. And so we just put out a need basket last year when we were hoping to have our inaugural capital fundraiser. We did not because it was scheduled for May 23rd, so I had to just let the Honorable Kathy Cox and Mayor Brian Bowman and a lot of dignitaries that were planned to be speaking know that it was off, and we were hoping to schedule it for May 8th this year at the Judy Silver Commons at the Maples Collegiate. However, we're going to have to cancel that because there's no way we're going to have gatherings of 200 to 400 people yet. Maybe next year, I have no idea, but we are envisioning having a building for second stage housing where we can offer what we've said. So right now we are offering the adult counseling. We don't have the capacity yet for child counseling. We are working on creating skills for employability. We are doing a lot of legal support, legal information, going to court with the women and advocating on their behalf. It's just a crazy, huge need for the legal area. I can't even emphasize, like, I just wish I could just go in and hold a whole seminar for judges and lawyers and Crown prosecutors on how to even recognize whether a perpetrator is continuing to use the system to hold power and control over a victim. It's just not a pretty picture. This is a flyer that I'm going to slightly change because the email, that is my old email, but we're slightly changing it. But this is the first community program that we offered. We finally got some grant money in the end of 2019 to start offering a 10-day 10 workshop, which is once a week, and it is held at the Seven Oaks Adult Learning Center on Jefferson Avenue in the Maples. And at these workshops, the women are gathering knowledge. Some of the women don't even have the language to identify what is abuse and what is not. They're breaking the isolation, so I'm sure you're well aware of the Break the Silence movement. During our second session, one of the women just looked around. There were 9 immigrant women who I had all screened who had been in abusive relationships. And she just said, "You mean I'm not the only one?" And I had tried to tell her that beforehand, but to be in a room, to see and hear the stories of other people is quite impactful. So they're acquiring tools for wellness and healthy relationships. They're building connections with a supportive network within the community. All I can say is that we're starting our third session April 9th, and I sure hope we don't have to revert to Zoom, because it makes a world of difference when you can actually physically be together. So, and then this, I'm going to see if I can actually get this bigger. Okay. Can you read that, or do you need it a bit bigger, maybe a bit bigger? So we just recently got some funding that is going to end the end of March, and I have another grant request with Manitoba Justice Victims of Violence to be able to transition from the end of March just for the next 3 years. I hope we get it, but at this point I don't know. But this is what we're offering. The directed empowerment part is the psychosocial support services and counseling. It is the practical support of legal supports and legal information and accompaniment. We do provide interpreters. The young lady that is at the bottom of this, the second email, speaks fluent Hindi, Persian, and Urdu. And so it's a lovely asset to have with us. And we offer transportation. So right now, when the weather is really cold, we can offer either Unicity taxi or Uber. And we work on employment. We work on housing needs. So I've got 2 women right now that need housing by the end of the month. So we're working on that. We also work on partnerships. So next week I have a meeting with Marie Rose Place because they have some vacancies of some 2-bedroom places. So it's busy, busy, busy. And I need to put that down. Okay, so then I just want to wrap up by saying any support, it doesn't matter if it's $5 or $500 or $10,000, we need everybody's support because it's not just a handful of the board. There's only 9 of us on the board. So I strongly believe that together we are making a difference in our community of Winnipeg, and we are supporting immigrant and refugee women who've been impacted by domestic abuse. So we're very proud of what we've done because our Mirrors program only started a year ago, February. And we thought we would be in our final session, but everything got elongated because of COVID-19. And so we adjust with that. So thank you very much for your interest. We are on Facebook, we are on Instagram, and we have a website. So I really would like to invite you to join us on our website. And I want to thank you for inviting me to your GNSA first virtual conference. And if there's any questions, I'd be happy to answer them.
Thank you so much, Sherry, and thank you for all the great work you're doing for the community. We do have time for maybe 1 or 2 more questions for our panelists. So this one is for you, Lea. How can non-Indigenous nurses and other healthcare professionals provide the space you spoke of for Indigenous clients and students?
You know, I think it's recognizing sometimes that, so I'll give you a concrete example. So right now we have, of course, outbreaks happening in some First Nations communities, and they're sending nurses to the First Nations communities, but it's based upon seniority, and that's a union thing. And so there are First Nations public health nurses that could go. Oh, I don't have my video on. There are First Nations public health nurses that could go. and would love to go and work in their communities, but because of you know, policies and a collective agreement and these kinds of things, they're not permitted to do so because it's strictly by seniority. So in a case like that, like, so right now we're actually going to be we have allies that are going to help us, non-Indigenous allies. So you can do something like this, where you would, you know, say, you know, this doesn't seem right, and become allies to Indigenous people or Indigenous nurses. And right now we're going to be putting something forth to the union to say, you know, really you should be sending people that are representative of the community that needs them, especially if they're willing to go and they're able to go. And so making the space in that way, or sometimes just stepping aside and saying, this doesn't feel right, I think it should be an Indigenous person doing this, and maybe that person doesn't have the seniority, but just stepping aside and sort of letting them step in. I hope that answers your question.
Great. And we have time for one more question. This question is for Rachel. You mentioned using AFM for assisting people with their substance use. I was wondering if you incorporate any harm reduction techniques into your teaching for your patients around substance use.
Hi, yes, yes, we do. And we do work very closely with our public health team. And also in our region, we do have a needle exchange program too. So we do offer that on site at the teen clinic if needed. We have special permissions to do some of that, but also a lot of language around safe use and decreasing use, or making sure that you're with people that you trust, that you're not in dangerous situations, or that you're not isolated. So those conversations happen quite a bit to make sure that youth are safe in those decisions. So I've never found that any sort of abstinence-only approach works in any context. So I usually go by, if they're opening up to me and starting to talk about this, that might already be a process in their stage of change. And so my purpose there is to kind of guide and direct them in how that could look for them, and how to be safer, and what the options are for them in terms of decreasing use. So yeah. I did notice, maybe I can make one quick point here too, and maybe some other panelists did too, but I did notice one question on mentorships. And I think mentoring, especially going into leadership roles or advanced practice nursing roles, is extremely important. And I think some of the others spoke to that too, as far as with nurse practitioners getting involved in groups like this, like the APN conference was an excellent way to network, except virtually it's a little bit more difficult to do that, but going, connecting with your clinical preceptors and just asking people. I think it's just a matter of asking, hey, can we talk more about this sometime? Can go a long way to helping you feel like you have support as you branch out into these new realms of advanced practice nursing.
Thank you, Rachel. So that is end of our APN conference. So I want to thank you again to all of our speakers for their excellent presentations and discussion, and to all of our participants for joining us today. I hope you found tonight's interesting and insightful as I did, and keep joining us for our future APN conferences. In the spirit of saving time and not taking too long, the winners for Amazing Door prizes will be contacted via email in a couple of days. And also a quick reminder that we'll be sending a survey just to get your thoughts on tonight's conference, and also about how to improve our upcoming and future conferences. We appreciate and thank you all for doing, especially all that you're doing, especially in our challenging times with COVID and being away from your families. So thank you very much. Take care, everyone, and good night.
Good night.